Hi, in this video we will read about neonatal shock. Let's start. A sick neonate may present with shock or it may appear during the course of disease. The success of management depends upon its early diagnosis and prompt and appropriate management. Definition: the term shock denotes the clinical state of poor perfusion of the body tissues in which the body's demands of the oxygen and nutrients are not met. Fine. It is a state in which there is poor perfusion and the body's demands of oxygen and nutrients are not met. This can result in tissue hypoxia and metabolic acidosis, causing irreversible tissue damage can even occur. Shock and hypotension are not synonyms, as hypotension is a late sign of shock. Okay. Hypotension it is a very important line, that we consider hypotension as a sign of shock, but that's not true. If hypotension is occurring, then it is a late sign of shock. Hypotension refers to the BP that is lower than expected reference range as measured by the non-invasive blood pressure method. Mean arterial pressure is roughly equal to the gestational age. Now, what are the learning objectives of this video? The objective is to identify the shock, perform fluid resuscitation, and use vasopressors and calculate their doses. So, first is the identification of shock. What will be seen in the children? Tachycardia. Unexplained tachycardia, heart rate of more than 160 per minute may be an early sign of shock. Heart rate can also increase if the baby is in pain or stress, or is hyperthermic, or is on drugs like caffeine. Fine, so these can also increase the heart rate. When can the heart rate be increased? If the baby is in pain or stress, hyperthermic, or is on drugs like caffeine. So first feature of shock that we read is tachycardia. Second thing is capillary refill time. This is the rate at which the capillaries refill following an emptying by the pressure and indicates adequacy of the tissue perfusion. So how are we going to check the CRT? CRT is checked on the central part of the body, such as sternum. Gentle pressure is applied by the fingertip for 3 to 5 seconds by slowly counting from 1 to 5. This results in the blanching of the underlying surface. Observe how fast the blanch area refills and becomes pink after the tip of the finger is lifted from the skin surface. Normally, capillary refill time is less than 3 seconds. A prolonged CRT of more than 3 seconds indicate poor circulation and tissue perfusion. However, this may be fallaciously prolonged in hypothermic babies also. So, babies who are in hypothermia can also have a prolonged CRT. Other clinical features of shock we read too. Now, let's see the other clinical features. Poor peripheral pulses, pallor, mottling of skin, cold extremities, decreased urine output, lethargy, and low blood pressure. Okay, these are the other clinical features in shock. Let's read that all again. First we saw was tachycardia. Second is CRT. Not CRT, prolonged CRT. Then poor peripheral pulses. Also in warm shock, the CRT will be less than 1 second. Poor peripheral pulses, pallor, mottling of skin, cold extremities, decreased urine output, lethargy or obtundation, and low blood pressure. So these are all the clinical features in shock. Now, low blood pressure is also a late sign of shock. Okay. Mottled skin and prolonged CRT can be seen in hypothermia, hence one must rule out hypothermia also. Now coming to the management. The outcome of the shock depends on early diagnosis and prompt management. Firstly, we have to do supportive management, that is to maintain the temperature, airway, breathing, circulation. Hypothermia, maintain normothermia, temperature between 36.5 to 37.5 degrees Celsius. Hypoxia, give oxygen to maintain the oxygen saturation between 91 to 95%. Hypoglycemia, maintain the normal blood glucose more than 45 mg per deciliter. Okay, so this is all about temperature, airway, breathing and circulation, and then we have to maintain the temperature, we have to maintain the oxygen saturation and the blood glucose. Now this was all supportive treatment. Now coming to the specific treatment. Restoring the perfusion is the cornerstone in shock management. Fluid resuscitation. Infuse the fluid bolus of 10 ml per kg of normal saline over 20 to 30 minutes. In baby weighing 3 kg, 30 ml of the normal saline should be infused over 30 minutes. Okay, so bolus is given in 10 ml per kg of normal saline over 20 to 30 minutes. This is very important. Now assess for the improvement by if there is the CRT which was prolonged has improved or not, or there is decrease in the heart rate by at least 10 beats per minute. So after this initial bolus, has the heart rate reduced? If no partial improvement, that is tachycardia and CRT still prolonged, repeat a bolus of 10 ml per kg of normal saline should be given. Improvement in the pulse volume and increase in the urine output over the next 4 to 6 hours is a sign of improvement. Okay, so we check for the improvement, but tachycardia and CRT are still prolonged, so we gave a repeat bolus of 10 ml per kg of normal saline, and then improvement in the pulse volume and increase in the urine output over next 4 to 6 hours is the sign of improvement. So first we gave fluid bolus of NS. Now second thing that we have to do is vasopressors. If the signs of poor perfusion persist despite 2 fluid boluses, start the vasopressor support. When we have to start the vasopressor support? If signs of poor perfusion persist despite 2 fluid boluses. This is very important, that when to start a vasopressor. Fine. After 2 fluid boluses, if the poor perfusion still persists. Along with the vasopressor support, care should be continued, underlying cause should be treated. Okay. The drugs are used to enhance the myocardial contractility and consequently the cardiac output. Some degree of myocardial depression is present in all types of shock. The most commonly used vasopressor in the neonatal practice is dopamine. Okay. Most commonly used vasopressor in the neonatal practice is dopamine. Dopamine is used as the first line agent, though dopamine affects all the 3 components. Preload, myocardial contractility. One second. Dopamine affects all the 3 components: preload, myocardial contractility and afterload. The most important effect on the afterload and myocardial contractility. Okay. So what is the dose of dopamine? Usually the starting dose is 10 microgram per kg per minute. This is the starting dose. And if no improvement occurs, the dose can be increased by increments of 5 microgram per kg every 20 to 30 minutes to a maximum of 20 microgram kg. Okay, so we started at 10, we can increase by 5 every 20 to 30 minutes and to a maximum of 20 microgram per kg. Okay, now how to give dopamine. Use insulin syringe for loading dopamine. 1 ml of the dopamine injection contains 40 mg dopamine. Firstly, we have to use insulin syringe. 1 ml contains what? 40 mg of dopamine. If the baby is weighing 2.5 kg, we want to start dopamine at the rate of 10 microgram per kg. This is 10 into 2.5. This gives us 25 microgram per minute needs to be started. We multiplied by 60 for 1 hour. So 1500 microgram per hour. Okay. Now we multiplied by 24 for whole day. So this comes out to be 36,000 microgram per day. That is 36 mg of dopamine in 24 hours. Because 1 ml contains 40 mg, so 36 mg will be contained in 0.9 ml. And for 8 hourly we have to start. So 8 hourly divided by 3, 12 mg, 0.3 ml of dopamine in 8 hours. This is how we are going to start the dopamine infusion. If we add 0.9 ml of dopamine in 24 ml of the fluid and give at the rate of 1 ml per hour with the syringe pump, we will give dopamine at the desired rate of 10 microgram per kg per minute. Okay, right. If the infusion pump is not available, then add 12 mg, that is 0.3 ml dopamine to 8-hour maintenance fluid and run at the desired rate of maintenance fluid. After starting the dopamine drip, monitor the neonate status of perfusion by assessing the heart rate, CRT and pulse volume. Okay, after starting, we have to look at heart rate, CRT and the pulse volume. If available, use a non-invasive blood pressure monitor to check the improvement of the blood pressure. Assess after 20 to 30 minutes, and if there is inappropriate response, increase the dopamine rate by 5 microgram per kg per minute by increasing the rate of infusion to 1.5 ml per hour to provide 15 microgram per kg per minute. Further increment can be done to reach up to 2 ml per hour, that is 20 microgram per kg per minute. On the other hand, with improvement in the perfusion, decrease the infusion rate in decrements of again 5 microgram per kg per minute. As long as the infant is on dopamine drip, the status of circulation needs to be monitored. If despite dopamine of 20 microgram per kg per minute, the baby continues to be in shock, dobutamine is the next inotrope of choice, as it has been used in similar doses along with the ongoing dopamine. This is very important. First line was dopamine we read, and if 20 microgram per kg per minute also has been given and the baby is still in shock, then we have to use dobutamine. Dobutamine is the next inotrope of choice and has to be used in similar doses along with the dopamine, the ongoing dopamine. Okay, so dobutamine improves the cardiac output and decreases the vascular resistance without increasing the heart rate. It mostly used in combination with dopamine to improve the cardiac output. We should know, right, that what the dobutamine does. Dobutamine improves the cardiac output and decreases the vascular resistance without increasing the heart rate. It is mostly used in the combination with combination with the dopamine to improve the cardiac output. It is also used to decrease the peripheral vascular resistance in asphyxia and improve the myocardial contractility. The dose is same as dopamine. Dobutamine 1 ml has 50 microgram. That's it. Here dopamine 1 ml has 40 microgram. Okay. We can also check this on the syringe, on the ampule. Here 1 ml has 50 mg, not microgram, sorry, mg. Now we gave dopamine and dobutamine. Now coming to the steroids in shock. Hydrocortisone may be considered in neonates who do not respond to maximal dose of both the dopamine and dobutamine. So this is a kind of third line. Who do not respond to maximal doses of both the dopamine and dobutamine, and maximum dose is again 20 microgram per kg per minute. Hydrocortisone can be given in a dose of 1 mg per kg in IV of 8 hourly. Then depending on the response, assess every 6 to 8 hours. It can be given every 8 hours in the dose of 1 mg per kg per dose for 2 to 3 days. Okay, now moving ahead to unresponsive shock. Now let's read about the unresponsive shock. Neonates with shock may respond to the above treatment in the presence of hypoglycemia, hypoxia and hypothermia, hyperkalemia, anemia, severe sepsis, pneumothorax and cardiac tamponade. Consider blood transfusion if the HB is less than 12 gram %. Consider referral after stabilization of temperature, oxygen and blood glucose in case of this unresponsive shock. Now coming to the therapeutic endpoints. Treatment should be modified as per the assessment and response to achieve. If the capillary refill time is less than 3 seconds, normal heart rate is there or not, normal pulses, warm extremities, normal blood pressure and the urine output of more than 1 ml per kg per hour. Weaning from the inotropes. Once hypotension improves, normal blood pressure for 6 to 8 hours and the tissue perfusion improves, inotropes should be tapered slowly at the rate of 5 microgram per kg per minute every 1 to 2 hourly, provided the neonate continues to maintain the above listed therapeutic endpoints. Okay. Now tapering of inotropes. Inotropes have to be tapered if the BP is more than 90th percentile Zubro's chart at any point of time. If the baby is stable at least for 6 to 8 hours after inotrope initiation, consider tapering the inotropes. When to start tapering? If the inotropes to be tapered if the BP is more than 98th percentile, if the baby is stable for at least 6 to 8 hours after inotropes initiation. The dose of dopamine and dobutamine should be reduced at the rate of 5 microgram per kg per minute every 1 to 2 hourly, provided the neonate continues to maintain the above listed therapeutic endpoints. Omit the inotropes when the neonate has been stable on 5 microgram per kg per minute of dopamine. So this is the lowest dose, right? We start even at 10, and by reducing, the final dose has come to 5 microgram per kg per minute. Then we have to stop the inotrope. Inotrope, which was added last, to be tapered first and omitted. Right, we started dopamine, then dobutamine. So dobutamine needs to be tapered first. Now, when to refer? If the neonate has unresponsive shock, in that case we also read when to refer. Okay, what to do if the referral is not possible? Then we have to continue the inotropes, consider use of adrenaline if possible. Adrenaline infusion at the rate of 0.2 microgram per kg per minute can be started. Assess the tissue perfusion after 20 to 30 minutes. If it is adequate, response increase by 0.1 microgram per kg per minute till a maximum of 1 microgram per kg per minute is reached, and continue the supportive care. Okay, so if the referral is not possible, then we can use adrenaline. And what is the infusion rate of adrenaline? It is 0.2 microgram per kg per minute, and maximum can be given up to 1 microgram per kg per minute by increasing the rate at 0.1 microgram per kg per minute. Okay. Now we have to, so the key message is monitor all the sick babies for the early signs of shock. Start the treatment immediately if the shock appears. Supportive care, fluid resuscitation and the inotropes are the mainstay of therapy. And this is a sample of monitoring for a sick neonate. We have to monitor the temperature, heart rate, respiratory rate, SpO2, CRT, mean blood pressure, urine output every 8 hourly, Downey score, Levin score, blood glucose, and serum electrolyte, serum calcium and blood urea and creatinine. So this was all about neonatal shock. Thank you.